Okay, hello everyone. This is Vijay Batuman. I'm the interim chair for the Deming Department of Medicine. It's my pleasure to introduce to you today's grand round and panelists. Our topic today is planning for a pandemic, palliative medicine and clinical ethics preparation. Our panelists are Dr. Sonia Malhotra. She's an assistant professor of medicine and pediatrics at Tulane School of Medicine. She is the Director of Palliative Medicine and Supportive Care, University Medical Center, New Orleans, and Tulane School of Medicine. She was recently appointed to the Louisiana statewide Palliative Care Interdisciplinary Council. She will be followed by Dr. Anjali Niyogi. She's an Associate Professor of Internal Medicine and Pediatrics. She is the co-director of Resident Initiative in Global Health at Tulane, and she is also an adjunct assistant professor, Department of Tropical Medicine. She is the co-chair of medical ethics at the University Medical Center, New Orleans. I must point out that both Dr. Malhotra and Dr. Niyogi were among the 10 recipients of 2020 Women in STEM Awards by the American Heart Association and Entergy. Dr. Niyogi will be followed by Dominica Fotino. She's an assistant professor of internal medicine. She's the co-chair of medical ethics at University Medical Center, New Orleans. Dr. Fotino has worked internationally with Doctors for Global Health in Chiapas, Mexico, and has clinical experience in Haiti and Romania. Our last speaker is Dr. Marlowe Maylin, assistant professor of medicine and the lead hospitalist. She is the chair of medical ethics at Tulane Medical Center. And it's my pleasure to introduce Doctors Sonia Malhotra to lead off the initial presentation. Thank you all for joining us today.
Dr. Brodeman, I think we have decided that I'm going to go first, if that's okay with you.
That's okay. Let's go.
Okay. Okay. So let me just begin. Here, let me see, share. Okay, so hopefully you guys can see this.
Yes, yes.
And we can kind of go from there. So my name is Marlowe Maylin. I am an assistant professor of medicine at Tulane. I'm also the chair of a very small ethics committee at Tulane Hospital. I'm hoping to make that bigger. I would like to take this opportunity to let you guys know that we do have a bioethicist on our staff, a Dr. Dukas, whom I have not met but hope to soon, and so he'll be a great resource for us, and hopefully will be joining the committee. You know, just wanted to remind you guys about the let me see if I get my slides to work. The basic ethical principles in medicine, which are autonomy, beneficence, confidentiality, do no harm, non-maleficence, equity, and justice. And so you can think about those things when we're talking about the things that we're going to continue to talk about today. This is just, you know, for everyone who already knows the current situation in the nation. It's pretty dire. Some areas are obviously harder hit than others. You can think of New York City as being one of those areas. And Louisiana or New Orleans was a hot spot as well. But currently we are doing fairly well at this time. And that has to do with a number of different resources that have been made available to us by the government, including ventilators, PPE, as well as the opening of the convention center for hospitals, for hospital beds and things like that. But you know, if we look back to a recent period where we, you know, basically surged or were expected to surge on around April 4th, which was this past weekend. That surge, you know, we were pretty close to consuming all of our ICU beds at that time. And so, this is why we're talking about kind of the ethical allocation of resources and what we've been thinking about in the weeks leading up to this period in time. You know, ethical principles and sound planning are really critical in time of crisis, and allow us as physicians to kind of plan and feel comfortable and make sound and important decisions. And so you can think of times where, you know, the ethical allocation of resources kind of came into play. You know, obviously wartime is a situation in which, you know, patients had to be prioritized. You could think of 9/11 and the massive trauma that occurred there, and the hospitals in New York being inundated with those patients and how they had to potentially triage those patients as well. Katrina here in New Orleans. The one thing I'd like to say about Katrina is that we were able to at least transport a lot of our patients out of New Orleans, and so they were able to receive care. Unlike COVID, we're not able to do that. Obviously, H1N1, which was concerning to become a pandemic, but never quite reached that the level of COVID, which is the time we're in now. And so back in the beginning of March, when we were starting to see cases in New Orleans, and realizing that these cases were community acquired and that the presence was probably here quite a bit before we realized it, we started to think about these ethical allocation of resources and started to review some literature. And so the NIH had published a manuscript and was published in the Annals of Internal Medicine in 2009. And basically, that was in response to the H1N1 concern. In that manuscript, there were several guiding principles. Really, the goal was maximizing the number of lives saved. That's the general guiding principle that they used. They recommended the use of a scoring tool to kind of assess patients' mortality or morbidity. In that particular manuscript, they commented on the SOFA, the Sequential Organ Failure Assessment Tool. They felt like scoring tools were appropriate and added the benefit of being objective and transparent. And it was allow for efficiency, but also acknowledging that lives have equal value and goal, but that the most lives should be saved. In the end, they decided that the singular approach was slightly error prone and that a multifactorial approach should be taken. In 2010, again, in response to H1N1, the VA, as well as a committee in New York, came together with consensus statements, which were similar in kind of guiding physicians and hospitals to start thinking about how, to allocate resources appropriately and ethically in a similar fashion. And then in around 2012 to 2013, this is another manual, and there are many more in literature, and this is the Scarce Resource Management and Crisis Standards of Care. This allows for algorithms and triage guidelines and worksheets. One of the guiding principles here is that medical surge is a complex multifactorial event, and the response and the operationalizing of allocating resources is equally as complex. And so it's important to have a guiding framework to help physicians and hospitals institute this. And so part of this is they outlined a framework beginning with conventional capacity and progressing through crisis capacity. And what this framework allows is for us to kind of alter, and accept the alteration in what we normally would consider the standard of care. And so it gives physicians some support and in that way. They also talked about in that article some guiding principles in relation to thinking about the allocation of resources and how we should think about these things. And again, a multifactorial approach. And so that's a nice resource if you want to look at that. And they talked about fairness and duty to care, proportionality, accountability, consistency, and transparency. Overall, I believe, though, that, again, it's still the guiding principle is that we should do our part to save the most lives that we can. So let me go forward to the next articles that we looked at in our planning, and that was an article from the CHEST journal, and again, ethical considerations in the care of the critically ill, and then another consensus statement from North Texas, and we use these two mostly to create our own policy and protocol or guiding principles at Tulane, which was recently approved by the MEC committee. The North Texas critical care guidelines is a nice tool to look at because it really lays out in an algorithmic fashion how to start looking at the ethical allocation of resources, how to operationalize that. It uses a lot of scoring tools, such as the modified sequential organ failure assessment and the Glasgow Coma scale. And basically, the purpose of the guidelines are to provide a triage protocol to allocate the scarce healthcare resources to those who are most likely to benefit medically during a pandemic or emergency. It implicates that physician judgment is important. And again, it's a graded guideline so that you can look at it. There's a lot of graphics involved in that statement, and you can look at those and kind of see how things are, how to institute and when to go from one step to the next. And again, it basically gives priority to patients who would potentially fare the best. Other things that it recommends is that the activation of the guidelines are pretty much instituted once state emergency is declared, which was declared in Louisiana quite a bit ago. Again, there's triage tools, there's inclusion and exclusion criteria, which are able to kind of help guide physicians in how to, again, approach patients and operationalize. It does recommend the establishment of a multidisciplinary committee that would assist physicians with implementing decisions, and it supports the formation and use of a palliative care committee to support patients and families. As you can imagine, there are many patients that may not be considered for treatment in this scenario. And so, palliative care is extremely important in helping those patients and families at that time. I'll finish with, or closing up with this new article from the New England Journal of Medicine, and this is in regards to COVID-19 specifically, and it's the fair allocation of scarce medical resources in the time of COVID-19. This is a table taken from that article, and the general ethical and guiding principles are to maximize benefits, generally save the most lives, to treat people equally, to promote and reward instrumental value, which is a little interesting because it puts potential priority on the lives of healthcare workers as opposed to other people. and the other areas that it gives priority to the worst off. And then it shows the way that you could potentially apply and operationalize this. And the point of this is to say that there are multiple different ways to institutionalize or operationalize that. Again, we have chosen at Tulane to really follow the North Texas critical care guidelines, in addition to the CHEST article in their guiding principles. I believe UMC has a similar policy or protocol, which the other speakers can allude to. Finally, I just want to say that there are a lot of other ethical considerations in this time, as you can see on the screen here: lack of PPE, having to force conversations about DNR, DNI, although in the end that may be a beneficial thing. The difficulty in contacting families, eliciting information from families, and/or making joint decisions. And if the family is unavailable to have to make unilateral decisions, that's difficult. The significant isolation of families and patients during this time, where visitors are not allowed into the hospital, the off-label use of experimental drugs in this time. There are ethical considerations around that. And finally, something that we're just touching on is the disparities in healthcare. And that's it for me.
Thank you, Dr. Maylin. Dr. Malhotra now is joining us. She will give us the second presentation. Dr. Malhotra.
Yes, I'm sorry about that. Thank you so much. I'm going to go ahead and share my screen. And I thank you all for your patience. Can you all see my screen?
Not yet.
Not yet.
Okay. I apologize. Okay.
Okay, now we do.
Perfect. Thank you all so much for having me speak in this forum. I apologize for getting on late. Now that we've had a few weeks under our belt to plan for this pandemic, I want to speak to the role of palliative medicine in this pandemic. And thank you, Dr. Maylin, for speaking on the clinical ethics part, which I am going to just touch briefly upon. And so one of the disclosures I have is I am a co-chair for the AHPM board review course. And first and foremost, I want to thank my team who has really pitched in. Knowing that this was a crisis mode, they have really come forward. So Dr. Christopher, Dr. Kate Jones, Dr. Katie Briggs, who extended her maternity leave to help us on the clinic side, and then Geraldine, our nurse practitioner, our physician assistant, Lauren Johns, and our social worker, Mandy. And then of course, thank you to my panelists, my co-panelists today for speaking on the clinical ethics concerns during this pandemic. I'm going to do three things: define palliative medicine roles in this pandemic, outline some communication techniques, and identify strategies for palliative medicine teams that might be listening in on how they can best contribute towards this preparation. So palliative medicine is the care of anyone with a serious illness. And generally, when I describe what we do, I describe it as fourfold. Number one, pain and symptom management, communication skills, emotional support, and then when appropriate, hospice and end-of-life care. And generally, we describe hospice and end-of-life care as one small segment of what palliative medicine doctors can do, with the bulk of it being upstream and helping with symptom management, communication, and support challenges for patients and families. I wish I could say, though, during this COVID pandemic that we haven't veered more towards the end-of-life category. This is a serious illness. The coronavirus is a serious illness like many others that we manage. And we have had to start for many patients at the diagnosis and follow them through towards the end of life. And really being able to take into the humanism parts of medical care and provide that during this devastating disease. I've learned 2 words during this whole course over the last 4 weeks: to be fluid and to be flexible, because things change very quickly. And even from my team's perspective, going from a 5-day-a-week, taking consults 5 days a week, to now all 7 days providing clinical care, we have all had to be fluid and flexible during this pandemic. So how have we structured ourselves? And a little bit for other palliative medicine teams in the region or nationally. We first started off with our emergency department and ensuring that our emergency department physicians and nurses were educated on medical power of attorney documentation. So upon admission to the hospital, whether it's in the ICU or on the medical surgical floors, our ED crew has been trained on documenting medical power of attorneys, and also knowing that coronavirus is affecting multiple family members from single families. We have actually trained them to also put into place a second contact point in case we have trouble reaching out to the first contact point. In the ICU and at University Medical Center, we are now up to 3 ICUs. We have actually developed an automated trigger to be consulted for any patient with coronavirus that is admitted to the ICU. During that process, we are rounding daily with the medical ICU and the trauma ICU and huddling with them early in the morning to gain a sense of any changes in the care plan. And we are providing a daily phone call to the family. If things are stable, we are generally allotting those phone calls out to our social worker if there are psychosocial concerns, to our chaplaincy group if there are spiritual concerns. Physicians, the 3 of us as physicians, are handling any more urgent or emergent calls or any sort of prognostication pieces. And then also assisting on the primary teams as well when they have the bandwidth to be able to call themselves. On the med-surg floors, we are participating in daily hospitalist huddles in the morning to be able to convey important information, including bed availability in our ICUs, and then making every 3-day phone calls to the family and encouraging, when we receive feedback from families, for the hospitalist teams to call those families. Additionally, palliative medicine, our group on the clinic side, has been very upstream. So we are continuing with our over 500 patient panel, continuing the care of these patients and providing telephone visits and moving towards a televideo option. Additionally, we have recruited members to help in doing advanced care planning for our patient population on the clinic side. And we have developed an Epic Smart Phrase to specifically address coronavirus concerns and whether patients would prefer hospitalization to being at home, and when they are aiming towards a more comfort-based approach to managing this virus, putting them in touch with hospices that are able to manage coronavirus patients. Our our outpatient census has not declined, and in fact, we have over 60 patients, new patients, waiting to be seen in queue. So how have we integrated our structure into clinical practice? Again, we are 7 days per week covering consults, and we've broken our team up into a primary attending with our social worker and our physician assistant. Our primary attending is on for 7 days a week to take new consults, and then we have a backup attending who serves as the overflow attending to take any other new consults. And I will say that our inpatient census has tripled through this pandemic. We are also arranging video iPad visits with families, knowing that visitor restrictions are quite high, and this is occurring all across the nation. And so the way we are able to coordinate care with families and allow families to see their loved ones is through video iPad visits. Advanced care plans for outpatients specific to the coronavirus, and really ensuring that if patients want to stay at home, that we have proper supports in place to help care for these individuals at home. And then bringing some level of humanism back to the practice of medicine. We've actually developed a Meet My Loved One sign to place outside of the door of every coronavirus patient. And we're moving towards the medical surgical floor. So nurses and primary teams know certain things about their patients, their hobbies, their loved ones, and how to contact them. And I know Dr. Fotino is going to talk about this, but we've also developed DNR, DNI signs to indicate readily from outside the door patients who have a do not resuscitate or a do not intubate order in place. In terms of documentation, we have created, University Medical Center is on an EPIC platform for electronic medical documentation. And so we have gone ahead and created several document types, initial consult notes, follow-up goals of care notes, as well as an advanced care planning documentation for clinic patients. We've also gone ahead and collaborated with support services, including the EASE program, which our operating room nurses are in charge of. The EASE program is a daily text messaging service. So once families are on that platform and have signed up for it, they can receive a daily text message on their phone with updates on their loved ones, and generally of three categories: green being that the patient's doing well, yellow meaning that they're stable with some changes, and red meaning that there are emergent changes and a physician will be calling them. And we have scripted those text messages. We also have a partnership with Child Life at Children's Hospital in New Orleans to provide child life therapists phone calls to children of patients with coronavirus to ensure their well-being and that they are being prepared for this serious illness. And then we've partnered very closely with Spiritual Care for spiritual counseling of families, and our spiritual care department and chaplaincy residents have been excellent. So goals of care, I wanted to really put this forward. You know, the basis of patient-doctor communication really is in building rapport so that a relationship is built and so that we as healthcare clinicians can provide recommendations. And that is what we're striving to do even during this pandemic. What we have done is the ask, tell, ask method, assessing understanding that families have of their loved one's disease, assessing their concerns, hopes, and then trying to match those with what we're able to offer medically that is reasonable. So we're using the ask, tell, ask approach, which, if you've heard of the Spikes protocol for breaking bad news, follows very similar to that. And we're participating in shared decision-making with our patients and their loved ones. So assessing their values and goals, and then talking about what reasonable next steps of care look like, and making recommendations for those next steps of care. And we're building that rapport through multiple conversations with families so that we are building rapport with them and we're gaining a better understanding of the patient in front of us and what is important to them, and matching medical recommendations to what the person values and hopes for. And I want to just put this up from JAMA, just published this March 27, 2020. You know, some level of informed assent is being recommended, some recommendations depending on the patient's goals and hopes. And then when families disagree with that, we're addressing those disagreements and ensuring that we are you know, providing support to families through that shared decision-making process. Prognostication is an important piece of what we as palliative medicine clinicians are doing. And so we round with our hospitalists as well as our ICU doctors daily so that we gain a sense of what our patients look like and what course that they are taking. And so some poor prognostic indicators that we've been able to see include the inability to supinate, knowing that proning is helping these patients and drying them out with the use of Lasix. The inability to supinate when blood pressures are dropping upon supination is one of the poor prognostic indicators that we relate to families. Clotting of hemodialysis lines when patients are appropriate for hemodialysis, tachyarrhythmias due to the concern of myocarditis related to coronavirus, late proning, if a patient is continuing to require proning after 7 days on the ventilator, and then lack of wakefulness off sedation once we are able to wean sedation. And our UMC critical care guidelines are up on the screen for you all to see. Outcomes, what we're seeing in terms of outcomes are really out of Washington State. And what we're seeing from Washington State is that there is a higher percent of deaths in the elderly, very similar to the Italian data that has been presented, and really higher hospitalization rates in elderly patients and geriatric patients, very similar to what was seen in Italy. In Louisiana, I think we have yet to accumulate data to see whether it truly is the elderly or middle-aged that is being affected more. I'm hopeful that we will have that data coming out soon. But what I can say is, as of yesterday, we have 16,284 cases reported and 582 deaths. You know, 1,996 of those patients are in the hospital, 519 on ventilators. So a lot of work that we're doing to ensure that we are speaking to families, preparing them for the unpredictability of this illness. Health disparities are also mattering, and they do matter in overall care, and we're seeing in this virus they matter. And so this is from the Louisiana Department of Health. The most common underlying comorbidities that we're seeing in our patient population is a history of diabetes, CKD, and obesity, which counted for 25% of cases. And then also a really high rate of our Black patients who are being affected by coronavirus and requiring hospitalization and ICU level of care. We do have end-of-life visitor policies at University Medical Center, and end-of-life care is a very important aspect of this virus, allowing visitors at the end of life with full PPE for up to 10 minutes, you know, post-mortem visitation is allowed with PPE as well. We wanted to strive to do the right thing despite being in a pandemic. And then we are also working on comfort care order sets for the floor and for the ICU to ensure that our patients are comfortable through the dying process, should that come to our patients. And then bereavement care, our social worker and social work intern have really taken the lead on this. So within 2 weeks of death are calling families, and then monthly for a full year after their death, and they are screening for complicated grief. And we have plans to start a bereavement clinic. We've collaborated with teams all across the hospital, and I want to stress that our psychiatry residency program at Tulane is helping us with making these phone calls, and we've provided them education on it. And we've really had to develop partnerships with IT as well as quality to relay information back. Education is the key to success. We have really worked hard to incorporate and put ourselves out to help in daily huddles and safety huddles, and ensure that you know, things are being appropriately escalated when they need to be. And consistency and repetition is what we have found to be best in relaying policies and procedures. We're also providing debriefings, knowing that this is leading to a high level of moral distress. And we've actually even debriefed our colleagues at Toro, who are also struggling with you know, doing something as normal as birth during such a crazy and unpredictable time in healthcare. Ethics, we've been a huge part of, as well as the regional palliative care and hospice calls to share best practices of care. And then some practical tips for those on the phone to integrate and incorporate. Ask your teams what they need, build a structure that you have to be fluid and flexible to change, and that clinics must go on. Patients out there are still seriously ill, and we must find ways to continue to care for them in the ambulatory setting. And so palliative medicine holds an important role in pandemic planning, and you know, we need to identify areas of support and integrate within institutional standards, including the care of patients from a medical surgical standpoint, ICU standpoint, and then integration into ethics teams to build ethical standards of care. So if you have a chance, follow me on Twitter, and I'm always available via email. Thank you so much.
Thank you, Dr. Malhotra. Our next speaker is Anjali Niyogi. Dr. Niyogi.
Dr. Malhotra, I need you to unshare your screen, please.
Dr. Malhotra, please unshare your screen so Dr. Niyogi can join.
Great. All right. Thank you, Drs. Maylin, Malhotra. My name is Anjali Niyogi. I am Assistant Professor of Medicine at Tulane and Co-Chair of the Ethics Committee at University Medical Center along with Dr. Fotino. So I just wanted to start off in some brief objectives. I'm going to be describing the role of the Ethics Committee in disasters and pandemics, and then also presenting some of the ethical guidelines that Dr. Maylin had alluded to in her talk about Tulane, at University Medical Center. I want to start off by saying that the standards of care, crisis standards of care, according to the Institute of Medicine, really supports and gives strong structure to the need for ethical considerations when creating these standards of care. As you can see from this pictorial here, at the very bottom are ethical considerations and legal authority. And those really are the basis and the foundation upon which all of the other planning takes place. And so what the IOM says is that just as in ordinary standards of care, crisis standards of care, when we are utilizing crisis standards of care, health practitioners must still adhere to ethical norms, and that we understand that there's going to be overwhelming scarcity and that autonomous decisions and choices by both patients and practitioners, so patient autonomy, may not be able to hold true, but that does not permit for violation of ethical norms. So I want to talk about our ethics committee at UMC. I'm very proud to say that our ethics committee from the start has always been fairly multidisciplinary. We've had input from chaplains and bioethicists, from our legal team, nursing, patient service experience and advocacy. Residents in training are also on our team, and a host of physicians. So internal medicine, ICU, emergency department, and palliative care are all very actively involved in our ethics committee from the start. And then furthermore, during this COVID pandemic, our committee has actually had enhanced participation, which I think has been really important. And so in addition to all of the people who already sit on our ethics committee, we've had people from anesthesia and surgery and radiology who may not necessarily be involved in day-to-day ethical decisions routinely are now being involved because we have so many more concepts to think about, such as how do we have resource allocation and how do we preserve our resources. The other thing that's happened is that we've been meeting far more frequently. And so since this pandemic started, from the first day that we had a patient at our hospital, the day after we had our first ethics meeting. And ethics has really been at the forefront, at the table, to provide some guidance for how do we go forward during this pandemic. And we have, as Dr. Malhotra alluded to, required a lot of flexibility and fluidity. And so our meetings have been weekly, sometimes twice weekly, just depending on what issues have come up. And so I really want to highlight the need for a multidisciplinary team of multiple stakeholders who are able to come together at a time and provide input from various points of views. So one of the first things that we did was to come up with ethical guidelines for crisis care at University Medical Center. And we used the guiding ethical principles that were alluded to in Dr. Maylin's talk. So fairness, which is that we need to be able to account for the needs of those at most risk. It's important to remember that people who were at risk before the pandemic tend to be the most vulnerable during the pandemic. And we're seeing that in Louisiana. And so it's really important to make sure that we are staying true to those. The other is duty to serve. So physicians are trained often to care for individual patients. And during pandemics and disasters, this shifts to where our focus really needs to be on population health. And then we also looked at the duty to steward resources, which becomes incredibly important when it comes to both healthcare personnel and PPEs. And then transparency to hospital staff and community, and then consistency, proportionality, and accountability. We, just like Dr. Maylin had alluded to, also used this CHEST article, which is Ethical Considerations in Care of the Critically Ill and Injured During Pandemics and Disasters, to come up with our guiding principles that we used at university. So I'm just going to run through the ones that we came up with. There's 12 of them. I'll read them quickly, and then we can discuss them as needed. So the first is that resources should not be held in reserve once a mass disaster or pandemic protocol is in effect. There is no ethical difference between withholding or withdrawing interventions, and educating regarding this fact shall be incorporated into training. And that triage systems based on even limited evidence are ethically preferable to those based on clinical judgment alone. Critical care resources should be allocated based on specific triage criteria, irrespective of whether the need for the resource is related to the current disaster, pandemic, or an unrelated critical illness or injury. It may be ethically permissible to use exclusion criteria for critical care resources, since the advantages of objectivity, equity, and transparency generally outweigh potential disadvantages. Protocols permitting the exclusion of patients from critical care during a mass disaster based on a high level of ongoing resource consumption may be ethically permissible. It is ethically permissible to identify certain resource-intensive therapies, procedures, or diagnostic tests that should be limited or excluded during crisis standards of care. Policies permitting the withdrawal of critical care interventions to reallocate to someone else based on a higher likelihood of benefit are ethically permissible. Patients who do not qualify under a mass critical care protocol for critical care receive DNR orders. Specific groups, such as healthcare workers or first responders, shall not receive enhanced access to scarce critical care resources when crisis standards of care are in effect. The one exception we made was for vaccinations based on a multiplier effect. Active life-ending procedures are not ethically permissible even during disasters or pandemics. However, symptom management is an ethically justifiable principle, and that hospitals and providers should communicate the definition of crisis standards of care clearly to patients and families, both on admission to the hospital and when triage decisions are communicated. And I just wanted to talk about some of the other ways in which the Ethics Committee has been involved, and one has been the visitor policy Dr. Malhotra has alluded to, code protocol that Dr. Fotino is going to speak about, an adjudication committee in case we come to the point of triage, developing a scarce resource triage guide, and then really promoting and advocating for communication with staff and providers. Okay. So that's what I have.
Thank you. Our next and last but not least speaker is Dr. Fotino. Dr. Fotino, we're happy to have you today in our panel.
Hello, thanks for having me. I'm Dominica Fotino. I'm the other co-chair of the Ethics Committee along with Dr. Niyogi. And I will focus on the Code Blue protocol that we came along with. I have no disclosures. Our rethinking our Code Blue protocol began when at the beginning of the pandemic, there was a vague understanding of how we were going to proceed with incorporating COVID-19, the COVID-19 diagnosis into code protocol. Was it going to change how we took care of patients or not? And so there began multiple discussions with the Ethics Committee and the various disciplines that Dr. Niyogi alluded to for how to address many topics, but codes as well. And we realized through our discussions that the diagnosis would actually not impact our attempts to address the underlying pathology. So in any code, there are underlying pathologies we think we may be able to assist with or not. And since COVID-19 did not play a role in that, we decided to not include it as part of the protocol. So we created an algorithm in efforts to, in the context of PPE shortage and with a top goal of protecting our healthcare workers, we created an algorithm that would modify a little bit the Code Blue protocol, but really focusing on conservation of PPE, and also reevaluating it in context of low mortality benefit that codes in general portend. This provided us an opportunity to revisit our code protocol. It's not completely done. We're still fine-tuning a few points, but I will present with you what we have today. So we distinguish between rapid response and codes because we are in the interest of limiting PPE use. For rapid responses, our goal was to have an ICU resident and the house supervisor come to evaluate the severity of the condition and thereby aiming to withhold PPE. We decided on a house supervisor versus a charge nurse or an MICU nurse because MICU nurses and charge nurses tend to have many more duties on the floor that can keep them tied up, and we didn't want to overburden them. So we thought a house supervisor would be a good person also because he or she would be familiar with bed availability and location. The goal was, of course, to stabilize the patient if intubation is necessary, preferably to really do that in the ICU where everything could be much more controlled, and if a line was indicated, to do that post-intubation. The main things I want to focus on here in the interest of time is the code team really, instead of it being from various specialties, really focusing on the anesthesiologist because he or she is the one who has the most experience with intubations, and the goal was really to aim for an expedited stabilization and minimizing utilization of resources. So in this context, not really utilizing the MICU residents and faculty. And the code, the team members are as listed below. The main thing is that there would be 2 runners outside to make supplies and medications available if necessary, but they would not be using PPE. And then 1 person outside would be in PPE prepared to come and relieve one of the code team members. The code algorithm that you see here is pretty similar, I think, to what we normally usually practice. I will point out one difference that we wanted to emphasize. I don't know if it's necessarily a difference, but something we would like to rethink. For people who are not on maximal therapy, if it's a PEA or asystole, it's as usual, address reversible causes. If they are not DNI or DNR, we would proceed with CPR and prioritize endotracheal tube placement. If it's respiratory failure intubating, and if it's VTAC or VFib, again, following the usual protocol with up to 10 minutes or 5 cycles of CPR, or if the code leader feels that it's not clinically indicated to proceed, to stop resuscitative efforts at that time. For patients who are on maximal therapy, meaning that they're intubated with max PEEP in the prone position on maximal pressor support, again, PEA or asystole, addressing reversible causes only, nothing else to do. For VTAC, VFib, if a shock is advised to shock, but to not proceed with chest compressions because they're already on maximal therapy, and chest compressions would be of no benefit. This DNR symbol is, as Dr. Malhotra alluded to it earlier, we felt that it was important to have a symbol to convey DNR in a non-aggressive, non-threatening way that would not necessarily be picked up by visitors if that would be upsetting to them, but also to be really consistent across the patient care team so that there wouldn't be a risk to A, breach the preferences of the patient and respect their wishes, but also to not overutilize PPE when unnecessary, so that should there be confusion and a team would go in and use up PPE, that would go to waste. So this was really an interest to maximize communication across all. And that's it for me. Any questions?
Thank you very much. I would like to thank the panelists for this excellent presentation and tackling these very difficult questions. There is one question from the audience, and I will read it to you. Perhaps Dr. Niyogi first try to answer, and maybe Dr. Malhotra can also comment. The questioner asked, the principle at UMC to not provide preferential care to healthcare workers and first responders who may be able to recover and provide further care directly conflict with recommendations of Ezekiel et al. Could you discuss your thinking?
Sure. So when we had those discussions, I think it really comes down to what staff availability you have. For UMC Medical Center, we have a robust staff and multiple health providers, and in an efforts to be as just and equitable as possible to all of the community and in interest of fairness, we decided that we would not prioritize our health staff getting those scarce resources, The exception that we made was for the vaccinations, because we do believe that protecting them would enable more staff to be present and continue to provide care. But we decided that we were going to have staff members, because of our numbers, be equal to the community members. I don't know if Dr. Fotino or Malhotra have anything to add to that.
Okay, any further comments? Another question related to that is from an anonymous attendee. Are the principles described the same at Tulane and UMC?
They are. If you can hear, this is Dr. Maylin from Tulane. The same principles are used at TUHC as they are at UMC.
Okay. Another question is 10-minute CPR duration evidence-based or our own consensus?
It's evidence-based. Even in the original guidelines, they don't say, they say up to 15-minute max, but some sources will say 10 minutes as well, and some say if even clinically indicated. So I think it's really a case-by-case basis. I don't know if Dr. Niyogi, Maylin, or Malhotra have anything else to say about that.
Any further comments from anyone else? Okay, there is a question from Dr. Potash. Addressed to Dr. Malhotra. Have you mailed prescriptions to established patients so they avoid running out of medicine while clinics are closed?
Absolutely. Our clinics remain open, and we actually have one of our attendings who is our refill attending, and we are in the practice of electronically prescribing any controlled substances so that we have greater control over those controlled substances. So yes, we do have one physician who is completely in charge every week of the clinic and refills to be able to do that.
Thank you. There's a question from Sarah Kazar. For research trials, will healthcare providers be preferentially assigned? Who would like to answer that?
I don't know if anybody from ID is on, but I don't believe that healthcare workers will be preferentially assigned any of the drug therapies. It's possible that healthcare workers will be first to be evaluated for antibodies and convalescent serum, only because of our risk of exposure and the likeliness that, that we may have been exposed already.
Okay. An interesting question. They're all interesting. From Scott Berman. First of all, wants to thank you for your hard work. His question is, do you think that ethical guidelines and hospital preparation for scenarios like this will change drastically when the dust settles? I think each one of you may want to comment on this.
Sure. I will say that when we came together as the ethics committee, one of the goals that we had was to ensure as much as possible that we're adhering to ethical norms and guidelines, even during standard care. And so when we weren't in a crisis situation. And I think that we found this to be an opportunity to address, just as Dr. Fotino had said, to address our code policy and to really think about what we are doing and how we practice healthcare in the United States and in our context. And so I think that coming out of this, I'm hoping that all of us will be a little bit more conscientious to think about our healthcare resources and the ways that we utilize them.
Any additional comments from anybody else?
I agree. Go ahead, Dr. Malhotra. Go ahead.
I'm sorry. Yeah, I would have to agree with that, and I would say that sometimes it takes a crisis for us to rethink how we have been doing things, and I'm hopeful that this will actually change practice and we'll be able to better utilize resources on a normal day and be able to have those open, clear communications with patients and families and not overpromise the world when it's not meeting patients' goals and hopes and values.
Thank you. Another attendee is, again, thanking all for the great panel. The question is regarding end-of-life visitations, is this something that other institutions are allowing as well? And how was the decision reached to limit it to 10 minutes in full PPE?
Yeah, that's a great question. I'm going to take that one because we've had many iterations of this end-of-life policy, and I will say that We are probably one of the more open institutions in allowing up to 3 individuals. There are some institutions that have completely said no to any visitation at the end of life. We recognize that it is important. It is the right thing to do to allow families to say goodbye to their loved ones. And so UMC and the LCMC system have really moved towards being able to provide that for patients and families. I can't say that there's any evidence base to the number of people or the number of time. Those are arbitrary numbers that we thought were reasonable within the context of our resources currently.
And I'll add to that, Tulane also has a similar policy with the exception of 2 visitors allowed for the 10-minute time period.
Thank you very much. I think we're approaching the end of time, but I want to close with a comment from Dr. Potash, who is one of our faculty in the audience and also is facing challenging ethical issues. He's expressing the opinion that the current response has avoided some of the mistakes made by the AIDS crisis. Would anyone like to elaborate on this comment?
I will say that I'm not old enough to have lived through the AIDS crisis. I have many mentors who went through that, and when I speak to them, it is eerily similar. And I think that whatever we as physicians and as healthcare clinicians can do to humanize the practice of medicine, despite being in a crisis, we need to focus on those things to do. It is the right thing to do, and we've all taken oaths. It's hard, and we all need to come together and recognize we're all stressed. And we all need to be able to support each other through these times and come up with sound protocols despite disagreement, come up with those sound protocols that make sense for patient-centered care.
Thank you.
And I would agree with that. I would just like to say, again, like Dr. Malhotra, I'm not able to speak on the AIDS crisis, but we can all in New Orleans, if we were here at the time, remember Katrina and some of the difficulties faced at Ochsner Baptist with a certain physician there who was left trying to make decisions regarding some patients who were in a critical time. And so, you know, we need to do this now. We need to make these decisions now, these guidelines now and protocols now, so that we are not in that similar situation and that we are supported and feel like we have resources that we can use.
Yes, and I would like to say the same as Dr. Maylin. I think one of the advantages we have is that we have some precedents to go by, and that it's really important to start planning early and to involve all of the stakeholders early.
Thank you very much. That's the end of our presentation. I want to thank again, once again, the panelists for preparing these very thoughtful presentations, and thank you all for participating. See you next week. Goodbye.